Afternoon. Can you hear me okay? I have the honor of introducing Dr. Afulani today. My name is Kim Baltel, and I work up on the third floor with in maternal neonatal health as well. There's a lot to say about Dr. Afulani. I cannot say it all, or I would take up all of her time to present. But she's an assistant professor in the Department of Epi and Biostats and OBGYN and Reproductive Sciences. She's affiliated with IGHS and the Bixby Center for Global Reproductive Health. Her research focuses on social and health system factors underpinning inequities in reproductive, maternal, neonatal, and child health. To this end, Dr. Afulani led the development of a person-centered maternity care scale that is widely used across the globe. Today, she's going to talk about a specific trial in her role as PI in the Person-Centered Equity Lab at UCSF, of which she is the PI, so I won't go into that. So there's a lot to say, but I won't go into it, as I mentioned earlier, but I did ask Dr. Dilys Walker, who couldn't be here to introduce her, what she would want you to know about Dr. Afulani if she was here introducing her. And she said, I would want to highlight her impressive journey from preterm birth initiative fellow to K recipient to R01 recipient and PI in just a few years. Most importantly, Dr. Afulani recognizes the importance and has nurtured the relationship with her Kenyan colleagues in a way that is respectful, builds trust, and assures equity. She is also unique in having bridged the global to local gap by bringing her insights and tools to the under and poorly served in California and the US. So with that, Dr. Afulani, we welcome you today. Thanks for coming.
Thank you, Kim, for the very kind introduction. And thank you all for choosing to be here this afternoon. I'm sure you have many other things you can be doing. I'm excited to present on our project that we call the Caring for Providers to Improve Patient Experience Intervention, CPIPE for short. So I'll be using CPIPE as I go along. And this is one of the projects that I am most excited about because it bridges two of the things I'm very interested in, the experience of the patient and the experience of the provider. I feel like it is one of those things you say, killing two birds with one stone. And so really excited to be talking about this today. All right. So the format for this presentation is I will spend some time describing the process towards the development of this intervention, which I think is important in understanding how we came to this particular intervention. And then I'll talk about the pilots that we implemented in Kenya the last 2 years, and then end with introducing the trial that we are just about to launch. So this is my amazing all-female Black woman team based at UCSF and Kenya here. This is a collaboration with KEMRI in Kenya, with global programs, and also with the Migori County Health Directorate. So I will use the term person-centered maternity care a lot, or PCMC, which refers to care that is responsive, compassionate, and respectful. You might have heard other terms like respectful care, obstetric violence, mistreatment, disrespect, and abuse. I choose to use person-centered maternity care because I think it's a broader term that captures all of these things, with things like mistreatment, disrespect, and abuse being on the negative end of the spectrum. And I'll spare you the details of why this is important, but really start by saying that despite all the evidence we have on the poor experiences women experience during pregnancy and childbirth, the evidence on how this influences health-seeking behavior, maternal and neonatal outcomes, there's still really very little empirical evidence on the best way or the most effective ways to improve person-centered maternity care. And so that was the motivation for this work, really thinking about how can we improve person-centered maternity care in a way that improves the experiences for all women, but also the experiences of the most vulnerable women. In the CPIPE intervention, we focus on two things: provider stress and bias. We also focus on both the provider experience and the patient experience. And I'll tell you more about why we focus on these as we go along. The initial work was implemented in Migori County, which is located in Western County, one of the counties with the highest maternal mortality. And I started working in Migori County as a postdoc with the Preterm Birth Initiative, as Kim mentioned. And I have continued to work in the county for the past almost 8 years now. So there's a context with the CPIPE study. When I started my postdoc here at UCSF, I was very interested in developing a quantitative measure for person-centered maternity care. And we did develop that tool, a tool for measuring person-centered maternity care. But I was also interested in the qualitative experiences of women during pregnancy and childbirth. And so the initial study that was called the Perceived Quality of Care During Childbirth study really focused on understanding experiences of women during childbirth in Migori County. This work led to an interest in better understanding the drivers of poor person-centered maternity care. So women were experiencing poor person-centered maternity care, but what were the factors driving this? And then from that initial work, I identified stress, burnout, bias as key factors. And so I developed a K99 R00 grant, really diving into these two factors to better understand how stress and bias showed up in person-centered maternity care, but really also to understand levels of stress and bias in the county. And the K99 led to the R00 phase of the work, which was then developing an intervention to address these factors. And we published a lot on this, but I'll go through and give you some quick highlights of the findings from each of these studies and how it led to the final intervention. So the PCMC scale was developed as a result of the work in the PQCC study. And based on that scale, we identified various gaps in PCMC with manifestations of disrespect and abuse, but especially poor communication and autonomy and lack of supportive care. A key finding from this also was the disparities in PCMC, with the poorest, the most vulnerable women being the ones who always or who usually receive the worst forms of care or who receive the poorest person-centered maternity care. And then in the next phase, as we started thinking about the drivers of poor person-centered care, two things kept coming up: provider burnout. So when you talk to providers about why women were mistreated during childbirth, one of the things that came up was the workload and the burnout. And these are just some quotations I pulled from a paper we did on this. So one provider talked about, maybe you call the doctor, this is an emergency. He or she comes with some stress from wherever he's come from. And when they come, they start to pour the anger on the patient by shouting. Another one talked about, whenever there's burnout, you just find yourself not giving the clients the best care you should. You find yourself treating the patients as if they are the cause of the burnout. And then when we started looking into why women are treated differently, why are certain groups of women more likely to receive respectful care than others, again, the issue of bias comes up. And one provider talked about a person who is well off, sometimes when they are coming to deliver, the other mother comes with one cloth, which is torn. They are not treated like the mother who has come with blankets and other things. Sometimes this mother has not bathed, there's just that humanity. And you feel like this woman, they are not treating them equally. Another talked about, it will be different when you know that somebody is from a high class or is well-informed. You will find yourself doing the right thing towards her, even when you are straining. Because I said that when you have shortage of staff, at times you try to run around, but we know that this individual is well-informed. And so we tend to come back to that rule. And so these were just initial findings that got me thinking about the issue of burnout and bias and really trying to explore a little more how this contributed to PCMC. And with several other, we conducted interviews with several providers. This was a mixed method study. We came to the conclusion that disrespect and abuse is driven by a health system and sociocultural environment that facilitates it. When providers are stressed, are experiencing difficult situations, they resort to disrespect and abuse as a means of gaining compliance. And then also that bias drives patterns of abuse. And so in a health system where, or in a sociocultural system where the poorest tend to be treated poorly anyway, in general, providers are just reflecting this in the healthcare system. And also that providers are not intentionally mistreating poor women, but they intentionally treat people of higher social class better, right? So when your default is being disrespectful, but when you meet somebody who challenges that social hierarchy, you pay attention. And when you are conscious about how you are treating people, you are more likely to treat them well. And so that led to CPIPE 1, where really we're trying to understand what are the levels of provider stress and burnout in this setting. And we documented high levels of moderate to high stress, low to high burnout. So about 2/3 of providers, actually more than 80%, were experiencing some degree of burnout. 20% were experiencing high burnout, which is considered clinical burnout in the setting. We asked questions around some of the factors that might contribute to this, including disrespect from patients, from colleagues, and from superiors. We had about a third reporting some disrespect from patients in the last year, disrespect from a colleague, and also about a quarter, actually a third also, reporting disrespect and abuse from a superior. And then we looked at what are some of those factors that contribute to burnout, high stress in the setting. And the contributing factors are well known. So high workload, lack of supplies and equipment were the most frequently cited source of stress and burnout. But there are other things like the poor salary, the attitudes of patients, family members. And one important one was a preventable death. So the trauma from constantly experiencing deaths that you know could have been prevented. And then also issues around staff turnover, personal issues, and I mentioned the attitudes of colleagues and superiors. And so just some quotations to illustrate some of this. Providers often talk about being the only person on duty on the antenatal ward, in the delivery, and the postnatal ward. So you find in a shift, you can be one nurse. You need to attend to MCH and ANC mothers. Then probably there's a mother in labor. There are those mothers who are in the postnatal ward requiring discharge, and you are one person. All these departments having one person manning at times can lead to burnout, and you end up not giving somebody that respectful care. And then they talked about sometimes the problems are as simple as reagents. Other times, they are as big as lack of oxygen. And then they talk about experiences where they know that certain deaths could have been prevented. So sometimes electricity goes off when a mother has delivered a preterm baby and there is no source of heat. So the baby ends up dying, a death that could have been avoided. The sad thing was that despite all of these experiences of stress and burnout, providers had very little support to deal with it. So something as basic as, have you ever had a stress management training? Over 80% of providers said they had never had a stress management training. Over 80% had no access to psychological, emotional support if they needed it. And similarly, over 80% had no access to peer support, although almost all of them said they would want this when we asked if they were interested in that. We also had about 2/3 mentioning they had no access to a mentor in their county. And even those who said they had mentors, these were mostly clinical mentors, not a mentor that you could go and talk about other things with. And then we did a deep dive into the issue of bias and how this shows up. And we found that providers are attracted to women based on their appearance. So if you go to the facility and you're dressed well, providers are more likely to be attracted to you. So one provider talked, maybe the one who is dirty and carelessly dressed, you just look at her, unlike the one who is well kept, clean and well dressed. Even if you don't know her, but she's well dressed, then you will treat her well. Mostly you'll find yourself not treating them equally. You see the clean one to be special than the other one. And then the assumptions of who is more likely to understand and be cooperative. So one provider talked about there are patients who are less likely to be cooperative in the sense that they have good understanding. And then goes on to talk about it depends on the environment where the client has come from. If a client is properly educated, the understanding level is good. But the one from the village, understanding level is low. They take a long time to understand, so it will make them not to cooperate well. And then finally, they talk about because you know that this person knows, you want to try and do what is ideal. But when handling someone who doesn't know, you seem not to care. So it does contribute. And so this way, we classify this as explicit bias because these are things that providers are aware of, that it affects their interactions with patients. And then we decided to measure implicit bias also. We developed an implicit association test based on the one that I'm guessing most of you are familiar with, but really focused on associations between characteristics that providers will consider that of a good patient and a difficult patient, and SES characteristics. And we found that providers were more likely to associate good patient characteristics with high SES characteristics and difficult patient characteristics with low SES characteristics. The interesting thing, however, was that it didn't mean that providers prefer to care for high SES patients. In fact, even though they had these associations, implicit associations, they prefer to care for the low SES patients because they were more likely to do what they were told, less likely to advocate for themselves, and less likely to speak up for themselves. So all of this put together, integrating with the literature, we know there is a large body of evidence on how burnout shows up in patient-provider interactions. Burnout leads to numbing, leads to reactivity, depersonalization, and all of that affects patient-provider interactions. Again, I talked about the fact that most of the disrespect and abuse is reactive and unconscious. And social psychology literature also tells us that deeply felt biases are more likely to emerge when people are stressed out. So not surprising that in the stressful work environment, you see evidence of bias very strongly. Despite that, stress bias are hardly discussed in quality improvement interventions in this context. So in the US, increasingly, there's a lot of discussion on implicit bias, but implicit bias is not something we think a lot about in this context. And so our goal was to design this intervention to improve PCMC, really focusing on these two things. We combined the formative research we had done with the existing literature with theory, and then this work was done in consultation with key stakeholders in the county. These were the three theories that informed the intervention. I won't go into this. I'm sure you're all familiar with social cognitive theory, ecological perspective, but trauma-informed system framework also, which recognizes stress as a source of trauma to the system, which if not addressed leads to numbing, reactivity, and depersonalization. So all of this work led us to the CPIPE intervention. CPIPE intervention has 5 strategies: training, peer support, mentorship, embedded champions, and leadership engagement. The training delivers content. Initial content is delivered over 2 days. It includes short didactic interactive content on person-centered maternity care, stress management, implicit bias awareness and mitigation, dealing with difficult situations. And all of this integrated into a simulation, high fidelity realistic simulation, a clinical simulation. If you've heard of Pronto, the Pronto simulation. So this is integrated into the Pronto simulation so that as providers learn about this, they have the opportunity to practice it while managing a clinical situation. Also, the 2 simulations we do here are on postpartum hemorrhage and neonatal resuscitation, which are actually sources of stress to providers also. So when identifying the things that stress them out, having a postpartum hemorrhage or having a baby come out floppy is usually a source of stress. So this is all integrated into that training. The initial training is followed by monthly refreshers over a period of 5 months. And then also we have this CADA-specific peer groups. So in the formative work that I didn't go into more detail, we asked providers what kind of peer groups they wanted. would you want peer groups that include the people from different caregivers in your facility or people specific to your caregiver? And that was what they preferred. So you have a group for nurses, you have a group for the clinical officers and the doctors, and a group for support staff. And these peer support groups are an opportunity to debrief on what is happening in your unit, but also to think through some of the issues you're having and brainstorm solutions on it. And then with the peer support groups, they are able to take minutes, and then they're able to share that with leadership in their facility, who then take it up to the next level of leadership to figure out a way to solve that. And if we have time, I'll come back to some of the ways these peer support groups led to improvements in addressing some of the sources of stress. And then we have a one-on-one mentorship program. And so we asked providers things they needed mentorship on and things they could provide mentorship on, and matched providers based on those needs. And this becomes a mentee-driven relationship after that. We encourage them to meet monthly, but really what they do after that depends on them. And then what we have what we call embedded champions, who are leaders identified within each of the facility to really drive all of these activities. So the refreshers are delivered by the embedded champions. After the 2-day training, we provide materials to them, and they do the refreshers in their facility. They help organize the support activities in their facility. The final component, leadership engagement, really is recognizing that most of what we do in intervention is really trying to help providers deal with stress and burnout without taking out the sources of stress and burnout. And so the leadership component is our approach to deal with that. That we have a community advisory board that's made up of leadership across the system in the county. So it has the county executive committee member, the county health director, leadership at the health facilities, who are supposed to guide on the discussion, on the intervention. But issues identified in the facility are brought to this meeting, and then they find ways of addressing them. So an example would be, for example, they bring up issues like, we don't have a blood pressure machine on the maternity ward. We have to go to the other ward to borrow when we are monitoring. And things like that they're able to address. Even things like, we need a bathroom in the maternity ward, that the women should have to go to the next unit to buy for privacy issues. All of those are brought to the leadership components, and they were able to address many of the issues that were brought to them. Anyway, so we piloted the intervention, and this was a pilot. I want to stress that, really to assess first feasibility. Can we do this? Is this acceptable to providers? And what are the preliminary effects? So for evaluating our pilot, we use a pre-test, post-test, non-equivalent control group design. The diagram there is trying to show that we had a control group and intervention group, conducted baseline in both groups, implemented the intervention over a period of 6 months in the intervention group, conducted our end line, and then we did additional in-depth interviews with providers in the intervention group. And after the end line, we did provide the training and intervention to those who were in the control group, but did not collect any additional data after that. These were the measures we assessed in this study: stress and implicit bias knowledge. We measured perceived stress and burnout, self-reported PCMC, and then explicit and implicit bias. For the in-depth interviews, we probed on their experiences with the intervention, how they were applying it, and also things around successes, challenges. Visual analysis, descriptive, we did some psychometric analysis I won't go into here, looked at bivariate, multivariate, and difference in difference analysis. And then we use a code thematic analysis for the qualitative data. Just want to highlight most of the participants. So we had, we trained over 60 providers in the initial intervention, but not everyone was part of the study. So for the study, we had 42 providers. At the end, we had complete data for 40 providers that I'm describing here. And then we had data from 40 providers in the control group. Most of the providers here were female, so most were in the 31 to 40-year-old group. Most were married, nurse midwives, and had worked for less than 10 years. There weren't very significant differences between the two groups at baseline, except for marital status. That was different for the two groups. And then just wanted to highlight the thing about training on stress, implicit bias, and unconscious bias. So less than 3% in both groups, like those participating in the intervention, reported any formal training on stress management. You had 3 and 5% reporting in the control group, reporting some training on unconscious bias, and then 15% training in the on both of these in the intervention group. So really from the onset, there was very little exposure to this type of training. I'll summarize the quantitative results. So at end line, we saw statistically significant changes from baseline in the intervention group. So increases in stress and bias knowledge scores. There was a decrease in both perceived stress and burnout, decrease in explicit bias scores, increase in self-reported PCMC. And then for the control group, there were no significant differences or much smaller differences. One exception was for implicit bias that I'll talk to. This is a busy slide, but just showing that in multivariate analysis, when we controlled for baseline characteristics, the differences remained significant. One interesting thing was we used the implicit association test, and one interesting thing we found was that there was no change in the implicit association test scores for the intervention group, but there was a change in the control group. And we have come to learn that the IAT has low retest reliability, and so it's not a good measure for evaluating interventions. So we're not using it going forward in the trial. But the other outcomes changed in the direction that we were expecting. Difference in difference analysis. So the intervention accounted for about a third up to 80% of many of the effects. Only the implicit knowledge change rate was statistically significant. So this is the interesting part of it for me, the qualitative data. So we analyzed the qualitative data. We identified themes that align with our theory of change, so social cognitive theory, the ecological perspective. So at the individual level, providers credited the intervention for increasing their knowledge and competency in stress management, in bias mitigation. They talked about how that increased their confidence as well as their attitudes and behaviors, resulting in positive impacts on their own personal well-being experience as providers, but also on their patients. So there was improved provider-provider interactions leading to supportive work environments, but also improved patient-provider interactions leading to improved PCMC. And then there was increased accountability at the institutional level, leading to a culture change. And finally, there was collective action and advocacy among providers to advocate to address the sources of change. So just some quotations to highlight some of that. One provider noted, "I now know how to calm down. I'm not the bitterness I was before. I know how to cope with the stresses that we are going through in the maternity. I can handle difficult cases. The way I used to freeze when I got emergencies, I no longer freeze. I breathe in and out, then I quickly do what is expected of me." Another one talked about, "Before we attended this training, we had discrimination. When we looked at an individual, like maybe this is a nurse or even a doctor, we want to give them the best attention compared to the other class of mothers who are dirty without anything. At least now we can give them equal service with no discrimination. If everybody can get to the seminar, we can change like me. Ever since I went for the training, I have changed." And then another talked about, "Sharing my stresses with my colleagues now made me to enjoy coming to work. And my anger towards patients was also dealt with. Before, I could shout at the mothers so much in the maternity without bothering that the mothers are in pain. And that is why maybe they are not cooperating. Nowadays, it's not easy to find me shouting at them. I no longer insult the mothers." And then some quotes on the interpersonal level on how it improved their interactions. Providers talked about how the change in their facility has been noticed in the community around them. So it said that's come to a point where community people are starting to say that Kehancha is good. So they no longer go to private facilities. They are saying that here we're treated well. Nobody is becoming rough with you. And then another one talked about, "Previously, we the providers never had time to laugh. But after the training, when we're going on with our refresher, we'll vent our stresses and share our experiences. And you feel good about your work. It's made me more open to my colleagues." And then finally, on increased accountability, providers talked about how they were reminding themselves when they saw that another provider was treating the patient in a biased way. So the training on conscious bias, the way somebody appeared, you could attend somebody based on how they look. But now that everybody is trained, when unconscious bias comes up, your colleagues are able to remind you of the unconscious bias training, and then you get back to your conscious self. You think that I should treat everybody the same. The training has really helped. And finally, on advocacy, that if it was not for us, certainly with the peer support meetings, putting pressure on our nursing officers as a team, who's also putting pressure on the top leadership, we saw miracles happen. Essential commodities, we have complained about them for a long time. Nothing was done until you came in. So really to summarize this, we think that the intervention had an effect as a result of a synergistic effect of the different components of the intervention. The findings were what we expected. It aligned with our theory of change, except for the implicit bias, which we acknowledge was more of a measurement problem. There are limitations. These are all self-reported from the providers themselves. We did not include patients in this study. But really, this is the first study to show the effect of such an integrated provider training, integrating stress, bias, but also person-centered care, quality of care. And we found that it's acceptable, it's effective, but there are limitations. And so we need to generate more robust effectiveness data in a larger sample. And because we're interested in person-centered maternity care, we need to hear from the women themselves to see have things changed in the facility. And that brings us to the CPIPE trial. And how am I doing on time? I can use 5 minutes to finish on this, or we can take questions on the first part if I touch on my
Yeah, another 5 minutes is fine.
Okay. So in the CPIPE study, we're really focused on assessing the effectiveness of the intervention on person-centered maternity care, measured from the perspective of mothers who receive care in the facility. And our second aim is looking at mechanism of impact, where we measure the same outcomes we measured in the initial trial. And this time we'll be looking at some distal effects also, some of the things we expect to change if you have improved person-centered maternity care. I'll show some of that. We are now expanding to an adjacent county in Kenya, which is Homa Bay County, but also to Ghana. So the trial will be done in Kenya and Ghana, in 2 regions in Ghana, 2 regions in, 2 counties in Kenya. Our investigator team has also expanded. You might see some names that you are familiar with up here. This in addition to our staff who are the same group of people continuing with us. It's going to be a cluster randomized control trial in 40 facilities across the 2 counties. And the design is very similar to what we had, except at this time we are randomizing the facilities to start off. And then we have a gap between what we had as end line before is now a midline. And then we'll have a period where we're trying to assess some sustainability and collecting data 12 months following. Yeah. We'll be following 400 top workers longitudinally, so across a year, collecting data at 3 time points. We'll be conducting interviews with 6,000 women across the 2 countries, and this will be data collected from multiple cross-sections of women at each of the 3 time points. It is the same intervention with some tweaks based on lessons we learned from the pilot. More detail I can come to if we have time. And this is the primary outcome now. We're using the person-centered maternity care scale that we developed in the county, and we are collecting data from others. Intermediate outcomes, the same as what we've used previously. And we'll be measuring postnatal care timing and breastfeeding as the start outcomes, and also postnatal depression. So some emerging studies showing that improvements in person-centered care leads to improvements in these outcomes. So we're measuring that and also other outcomes here. We are in the pre-launch phase. So we just completed some stakeholder meetings in Kenya in the last month. We are getting all the approvals we need, and we are hoping to launch fully with baseline in January. The intervention development paper, process is published if you want to read more about that. The evaluation is still under review. We'll have a preference up also if you are interested. And both trials are registered, and you can find more information on our website. This has been teamwork with several people involved, and I'd like to acknowledge funding from NICHD. They funded both the K99 R00 and the R01. And I will stop here and take questions.
Oh, yeah.
Hello. Well, hi, everyone. Is this working?
Yes.
Okay. Thank you, Doctor, for that incredible presentation. I'm Sarah Solomon. I'm a Global Health Master's student here, and I'm going to begin the Q&A portion. I'll just get the ball rolling, and then if you have questions, you can join in. So I read the article recently, and as stated in the limitation, the interventions didn't take into account structural factors. And I see that you deemed it important to take an individualized approach. And so I'm wondering why you deem that to be important. And it seems that you kept the provider's well-being at the center of it all, which is why you took into account the cognitive properties. So I was wondering why you deemed it important to take an individualized and theory, specifically social cognitive theory-based approach.
Great questions. So the ideal situation is that you remove all of these sources of stress, right? Then you don't have to deal with them. That is something that is hard to do from an individual project. And so really, it's working. Yes. Okay. So really, we started this project thinking about how can we help providers deal with the situation they have to deal with anyway? How can we help them be more sort of resilient? So it's interesting, this morning I was listening to a podcast where they talked about external and internal, primary and secondary control. The ideal situation is primary control, where you take away the stress or you take away the symptoms. But also sometimes we underestimate the value of a secondary control, where people are able to reassess the situation differently and think of how they are responding to the situation. And so we took this approach from a feasibility point, what we can do. We can't increase the number of providers in Kenya. We can't go and provide all of the supplies they have there. But our leadership engagement component was our attempt to address that. How can we mobilize leadership to think about these issues and think about how they can address the sources? And so that was why we ended up with this intervention, very individual focused. There is some organizational focus to it, but not as big as, you could if it was a big program. Remember, this was K99 at zero with $50,000. So it wasn't a lot of money.
For that answer. I'll go into the next question, and after that we can take audience questions. So something that's came to mind now that I'm kind of curious about. So we learned in social determinants of health a lot about the metrics of certain interventions, and are they measuring what they're supposed to measure in certain geopolitical contexts? So I'm just wondering, would this intervention be applicable maybe here in the US, where biases are kind of different? It's more so racially based, because it seems like the biases in Kenya are more so based on economic standing. So I'm just wondering, is it applicable across geopolitical contexts?
Good question. So what I think is the strategies will be applicable, not the specific content of what went into each of those. So if you think about some of the work that's actually the critique of the implicit bias work is that it's all training so far. So training is definitely applicable. But then the other strategies, so actually, interestingly, a lot of facilities here, maybe Ken can speak to that, have debriefing sessions, right? So there's some form of that peer support going on, maybe not exactly what we're doing. People here have more access to mentorship than in those settings. So it might not be, the need is different. I think the need is different here, but the strategies could be applied. You would need to think more carefully about the content of what you are doing.
Thank you very much. Audience questions?
Hi, thank you so much. I was interested in the infographic for the CPIPE study and noticed that with the control after the 6 month and then the kind of the re-entry into data collection, there's an intervention after that. I was curious to hear more about the rationale behind that and what that will look like.
Thank you. So the intervention at the end line was part of our engagement strategy. So when we started engaging the county, it was like, how can you collect all of this data from us and not do anything for us at the end of the period? So it's really not part of the study. It's just that after we're done with our study, we present the same intervention to them. And we started this assuming that it would work. And so because it would work, sort of we're ethically obliged to implement the intervention with the control group. And so that's why we're not collecting any data after that. It's just for us to be able to offer them that we've collected so much data from you over a period of a year. If you are interested, here's the intervention that is available to you.
I actually have a question. Thank you so much. You know, I'm a big fan of your work, and we work in somewhat similar spaces. We've gone in our studies to looking at quality of care. So in the patient chart, in other words, if a nurse or midwife is less stressed and has peer support, do they actually perform better in those tasks that keep patients safe? And I know you have some patient outcomes in the CPIPE trial coming, but will you look at quality of care? Because ultimately this is to have better patient outcomes. So I'm just wondering a little bit about that.
Yeah, thank you. That's a good question and something we have talked about. So we are collecting some facility data, but it's mostly focused on utilization. So we're looking at sort of mortality, morbidity data at the facility, recognizing that, so we say these are distal outcomes. In our proposal, we said these were exploratory because that the timeline might not be enough for us to see morbidity, mortality changes, but we'll collect data on them anyway. We didn't include sort of assessing quality of care from charts and observations because it costs us too much for us being able to collect that level of data. So we're skipping that and looking at the outcomes, assuming that quality of care improves, then mortality should decrease in that facility. Yeah, but it will be interesting to do if we could actually measure the quality of the processes. It tends to be very labor intensive, as you would know.
Thank you so much for the very excellent presentation. I saw that in the upcoming trials, you are talking about considering or exploring potential sustainability approaches, and I was wondering how can we do that, because we always do go with the intervention and do it, and then after the project finish, we fail to sustain.
Yeah, great question. Thanks for asking that. So in the pilot study, one of our sort of sustainability approaches was the champions, right? That we have these champions that we have provided information, have trained. They actually did the training for the control group. So when we went to do the training for our control group, the champions were the ones who came to do that training. And then they provided mentorship to the champions from the control group. So we tested that out in the pilot. And so in this phase, what we're doing is that we have this 6 months intensive period that we are working with them continuously over 6 months. And then we collect the data. After that, we leave them and encourage them to continue the activities themselves. And then we come 6 months later to see what has happened since we left. And our sort of hypothesis is that having these champions in the facility, they would continue with the activities after the intervention is over. 6 months is really still short, but at least we think that that gives us some evidence of what happens after the intervention is done and no longer actively involved there.
I have a patient question. Thank you, Patience. Fantastic presentation and really impressive body of work. I had a question about a small thing, but I saw it on a few slides you referred to working with a CAB, a Community Advisory Board. And I was just wondering if you could share a little bit about your experience in how you chose them, recruiting them, how you engaged with them. Because, you know, I think we see this more and more as a standard in working, especially in global health. So would love to hear your experience.
Yeah, happy to speak to that. And we went back and forth on whether we should call it a community advisory board, a county advisory board. Now we're thinking community advisory group. So the name does not matter as much, except that what we did was, starting from the very beginning, we approached the county leadership, let them know about this intervention, and invite them to provide feedback on the initial strategies, even before we did the implementation. And we asked for representatives from all the levels. So at the county level, we had the county executive committee member who is like the Minister of Health at the county, actually being the chair of our community advisory board. And then we had the director for health services. And then we had representatives from each of the facilities. So the medical suit, the nursing officer from each of the facilities involved. We had a doctor representative, a clinical officer representative, a representative for the nurses. We had a community health volunteer representative. And we brought these together. We organized quarterly meetings with them. During the meetings, we shared what we have done, asked for feedback. And then during those meetings also, the champions reported what has happened in their facilities and some of the challenges that they were dealing with. And so it provided an opportunity to think through and address them. And so we're hoping to continue with that in the trial also. That was a very important part of the study, being able to bring these people together. There are some challenges I can talk about. That's when you have somebody like the county executive committee member. That's a political position. So they may change and new people will come. So there was some constant sort of re-engaging as new leaders came into the system. Yeah.
Great, thank you.
Thank you again for coming. So I've been following CCARE, the Centers for Compassion, Altruism, Research, and Education at Stanford, and they've had a lot of success teaching compassion fatigue and like mechanisms to deal with compassion fatigue. And I was curious if you think compassion is an issue, and if you've considered teaching compassion fatigue.
That's a good question. Thanks for asking that. So we have taught about compassion fatigue. I haven't considered teaching it, not because it's not, it's not good, but in terms of how we thought through developing this intervention, we're really trying to focus on not just not just compassion, that there were several things that happened around an individual that led to how they interacted with the patients. And we're trying to deal with all of these simultaneously. It could be a good approach in this setting. I haven't tried it out. I don't know how it will work. But I think it's a potentially useful approach. I won't do it in isolation though, just teaching that.
Thank you.
Question. Time for one more question.
Thank you so much, Doc. And on behalf of the people of Migori, I would want to say thank you so much for what you're doing down there. I happen to come from that place, and the issue of health systems and strengthening is very dear to my heart. So my ancestors will be shocked that I didn't say thank you for what you're doing there. But moving on to the core of the study, I wanted to know if there was any reason why you excluded non-government facilities. There are quite a number of religious and community-based and private institutions that are there. And I think from my experience, occasionally the inequities in spaces where they don't have government regulations or a mainstream guidance on what should be happening, there's tendency to deviate, and sometimes, especially for the area of pregnancy and childbirth, these are normally sometimes the first interventions and things like TBS. I don't know if you have any thoughts of trying to look at that space. Thank you.
Yeah, thank you. That's a great question. So in the PQCC study, we actually included private facilities, non-government facilities in the initial study. When we came to the CPIPE trial, as you can see, I don't know if I mentioned, so we had 2 facilities that were involved, like intervention facilities and 4 control facilities. And we selected those facilities together with the county in terms of where they thought the need was. When we just moved to Homa Bay, our initial list included private facilities. And then when we met with the county director mentioned he didn't have as much control over private facilities, because one of the things we were asking during our meeting was, can they not transfer providers within those 6 months that they are actively engaged in the intervention? And they said they had no control over the private facilities, and so recommended that we stick to public facilities for the trial also. So unfortunately, we don't have any private facilities, not because we don't want to, but it's more of a logistical issue. But I should say that in the PQC study, PCMC scores tend to be higher in the private facilities compared to the public facilities. So from a need perspective also, it seems that there are more problems with providing person-centered care in the public than the private facilities there. Hopefully we'll get money to do in all the facilities, and then we can expand to private facilities.
I know there are some questions online, but I'm afraid that we're out of time. But thank you so much, Patience, for your presentation and for sharing your work with us, and look forward to hearing more about it as you move forward. And thank you, Sarah, for emceeing. And everybody, yeah, have a great rest of your day. And Dr. Afulani, if people have additional questions, okay to contact you directly?
Yes, please.
Okay, great. All right, thank you so much.